So this is one of the videos that I thought I had actually done on my channel, but realized that I didn't. So here's a quick video on Tetralogy of Fallot. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Mosesjrk. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at Tetralogy of Fallot. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon so you never miss on such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. Remember that on our channel we are still running our X-ray videos. I will post the second part of the X-ray video, so please stay tuned to that. But we will still continue with our normal usual lectures on the channel. So remember that in terms of congenital heart diseases, they can be divided largely into two main types. We have what are referred to as cyanotic congenital heart diseases because they are characterized by cyanosis, which is this bluish discoloration of the skin and the mucous membranes. Then you have acyanotic conditions which pretty much do not present with cyanosis. The reason why these cyanotic congenital heart diseases are presenting with cyanosis is because the shunting of blood from the right side, which is blood that is meant to go to the lungs for the purpose of oxygenation, and this blood is shunted to the left side of the body. So therefore, the deoxygenated blood mixes with the oxygenated blood, and overall this reduces the oxygen carrying capacity of the blood and it causes bluish discoloration of the skin. So often these cyanotic congenital heart diseases, like I said, are going to have some sort of shunting of the blood past the lungs. So we call these as right to left shunts. And these cyanotic congenital heart diseases are going to be quite evident, and the cyanosis will be evident when you have this deoxygenated blood of approximately about 5 grams per deciliter mixing with the systemic blood, mixing with the oxygenated blood. So if you get a patient that is polycythemic, they will appear cyanotic even with lower percentages of this reduced hemoglobin, and patients with anemia may require a higher percentage of reduced hemoglobin for you to actually be able to see the cyanosis because they tend to be quite pale. So just a little bit about cyanosis before we actually go into greater details. Remember that it can be peripheral, meaning it's the extremities. As you can see in this baby here, the extremities are bluish. This is known as peripheral cyanosis. Or it can be central, where the lips, as you can see even in this particular picture at the bottom, the lips, in addition to this child has some finger clubbing. So it's not strange to actually conclude that this child may have a congenital heart disease. So in terms of peripheral cyanosis, it's often due to vasomotor instability or due to some sort of vasoconstriction. Could be as a result of cold temperature. Then in terms of the central cyanosis, as seen in these two pictures, it's going to be pretty much the tongue and the inner mucous membranes, and this is going to be attributed to both cardiac as well as non-cardiac causes. The non-cardiac causes are things like pulmonary disease, sepsis, hypoglycemia, polycythemia, neuromuscular diseases that may even impair the chest wall movement. While as the cardiac causes, remember the 5 T's. Tetralogy of Fallot, which we will talk about in this lecture, transposition of the great vessels, tricuspid atresia, truncus atriosus, and even total anomalous pulmonary venous return. Remember that the most cyanotic heart lesions, most of them are going to be presenting within the neonatal period. You generally have the most common congenital heart disease being Tetralogy of Fallot. Tetralogy meaning that there are 4 features that are there. So there is this right ventricular outflow obstruction, an infundibular type of stenosis, and even some pulmonary stenosis that may be there. The blood is not really leaving through the outflow of the right ventricle. So remember that there's now more blood that is pooling inside the right side of the heart. So it's even putting more stress on the walls on the right side of the heart. So this leads to hypertrophy of that side. So there is some right ventricular hypertrophy. In addition to this, there is a defect that is there, a shunt that is there between the right ventricle and the left ventricle, which is known as a ventricular septal defect. And this is a quite large defect. So you have a very large ventricular septal defect and you have the overriding of the aorta. So remember that the aorta and the pulmonary trunk are pretty much going to develop from one particular structure that is known as the aorticopulmonary trunk. And in overriding of the aorta, instead of the aorta actually arising from just over the left ventricle, it's going to be malaligned and it's going to be displaced. and sort of like will be right at the septum, further also contributing to the obstruction to some extent. So this is what's happening. As you can see here, we have the overriding of the aorta, which is coming right, arising from the septal area here, or just overlaying the septal area. You have a very large ventricular septal defect, and you have this blood that is going to be on the left side being pushed to the right side. So there's more blood on the right side, there's more shunting of this from the right side to from the left side to the right side rather, and this is going to cause more stress on the walls of the myocardium on the right side. So it causes the right ventricle to be thickened. In addition to this, you also have a narrowing of the pulmonary vessel. So again, this side of the heart has to generate a much greater force to overcome this resistance there, further contributing to the stress, further contributing to the hypertrophy. So those are the 4 things that we often see in patients that have tetralogy of Fallot. So in terms of other associated defects, you may have right aortic arch. In 25% of the patients, you may have abnormal coronary artery anatomy. In 5 to 10%, you may have stenosis of the pulmonary artery and the branches. You may have the presence of the anaiotic or pulmonary collateral vessels. You may have a patent ductus atriosum. You may have a complete atrioseptal defect. You may have additional muscular and even these are ventricular septal defects, additional VSDs to the large VSD that you have. You may have aortic regurgitation as well. So remember that this is the most common cyanotic congenital cardiac disease, especially in children beyond infancy, and it's going to be accounting for roughly about 7 to 10% of all congenital defects. It is a quite common cyanotic congenital heart lesion, and most of the patients that survive during adulthood are going to have this lesion, the Tetralogy of Fallot. Remember that if you do not actually correct it, the mortality rates could be as high as 50% by the time the child is 6 years old. However, because we have more advances in medicine, we have the introduction of cardiac surgery, it means that Tetralogy of Fallot, those that are suffering from it, can actually have a long-term survival that is much, much better and even an excellent quality of life. It is the most common lesion to be encountered in adult population after repair. And remember that in terms of the corrective surgery, it's going to be performed in childhood. And this is not curative surgery. And as a result, many of the children with this repaired Tetralogy of Fallot are going to survive into adulthood and are actually seen in the cardiac clinics. Some of the patients that do have a mild Tetralogy of Fallot and do not go into surgery or don't need surgery may actually present as adults with various symptoms, and other patients who only had the palliative procedure, like for example, they had a shunt done, like a Blalock-Talsig procedure, then they can also present as adults with a various myriad of symptoms. And remember that Tetralogy of Fallot is going to be the first cyanotic congenital heart lesion to actually be successfully managed by surgical palliation, and it is the first cardiac lesion to actually undergo successful intracardiac repair. Those are just some facts that you must keep in mind. So what exactly is happening in these patients that have Tetralogy of Fallot? Remember that they have a ventricular septal defect that is very, very large. And remember that this same ventricular septal defect is going to be of a malalignment type. So what do I mean? The conal septum of the heart is actually going to be displaced anteriorly, and it's going to actually even protrude into the pulmonary outflow. Then this is going to also worsen the obstruction, and sometimes the hypoplasia of it may cause hypoplasia of the downstream structures. So things like the pulmonary valve, the main pulmonary artery, and even the branches of the pulmonary arteries. And because you have this very large defect that is there between the right and the left ventricle, it's going to mean that the pressure is essentially in the right ventricle, pressure is essentially in the left ventricle, and even to some extent the pressures in the aorta are going to be the same. So that means that the degree of which now you're going to have the shunting of the blood is going to depend on the degree of the right ventricular outflow obstruction, such that if you have a patient that has a mild obstruction, generally you're going to have a net left to right shunt through the VSD, and generally there won't be much cyanosis, because if you're shunting blood from the left side to the right side, remember that blood going on the right side is often going to the lungs for the purpose of oxygenation, so they may not be cyanotic. But if there is a severe obstruction, a severe right ventricular outflow obstruction, then there's going to be a right to left shunt, and this is going to be resulting in this low systemic arterial saturation, which is cyanosis essentially, and it's going to be unresponsive to supplemental oxygen. In some children with unrepaired Tetralogy of Fallot, most often Those several months up to like about 2 years, they'll have this sudden episodes of these attacks, which we call as a hypercyanotic spells, or what we call as TET spells. And these can be triggered by many things. Any event that is going to lead to a decrease in oxygen saturation, something like crying when they defecate, may trigger them to go into a hypercyanotic attack or a TET spell. It could be a suddenly decrease in the systemic vascular resistance. For example, if they're playing, if they are kicking legs when they are waking up, or even just a sudden onset of tachycardia or hypovolemia. All these things are going to be triggering the Tetralogy of Fallot spells. And how exactly this mechanism happens is not so clear, but there are several factors that actually have been implicated that cause an increase in the right to left shunting of the blood, and therefore a fall in the oxygen saturation. So if you get an increase in the right ventricular outflows obstruction, remember that the pressures across the VSD are essentially the same. But now you have on the right side, there's an obstruction which is very severe, so it will facilitate more blood being shunted from the right side to the left side. If there's anything that is increasing the pulmonary vascular resistance, could be things like crying, screaming, they're going to be increasing the pulmonary vascular resistance. So there's, again, more blood that is being shunted from the right side to the left side. If there's anything that is causing systemic vascular resistance to decrease, it will further shunt blood from the right side to the left side. Because remember, blood is moving from an area of high pressure or high resistance to an area of low resistance. So these events are then going to create a vicious cycle, and initially there's going to be an initial fall in the arterial partial pressure of oxygen, and this is going to stimulate your respiratory centers, which will cause hyperapnea, and it's also going to be increasing the adrenergic tone. So this increase in this production of these catecholamines is going to stimulate increase in contractility, and this is going to further worsen the obstruction, creating a vicious cycle. So as the name suggests, you have four anatomic abnormalities. You have a right ventricular outflow obstruction, you have right ventricular hypertrophy, you have overriding of the aorta, and you have a very large ventricular septal defect. And remember that the degree of the severity of the right outflow obstruction is going to determine how much blood or where the shunt is going, whether it's going to be a right to left shunt or whether there won't be a shunt at all. This is very important because there's a particular position that you can actually place the infants to actually help with this shunting of blood and prevent this shunting of blood. So because of this right ventricular outflow obstruction, the blood is going to be flowing from the right side to the left side across the VSD and then into the overriding aorta. And as a result, these deoxygenated blood mixing with oxygenated blood and therefore resulting in the cyanosis. So most often it's going to be diagnosed antenatally, or it could be following identification of a murmur, especially in the first 2 months of life, or it could be cyanosis at any stage that may not be obvious, although a few present with very severe cyanosis in the first day of life. In terms of neonates that do have a severe right ventricular outflow obstruction, or if they have atresia, these ones are going to be presenting with severe cyanosis. They'll have dyspnea, especially will be quite intense when they're feeding, and this is going to lead to failure to thrive and poor weight gain. Then the neonates with mild obstruction generally may not even have cyanosis at rest. They may become cyanotic when they become quite active. So remember that these hypercyanotic spells are going to be precipitated by some sort of activity. And it's going to be characterized by these sudden paroxysmal onset of hyperapnea, where they have this rapid and deep respirations. They'll be having this irritability, inconsolable crying, and they'll present with cyanosis, and generally it decreases in intensity or disappears. As the cyanosis is increasing, the heart murmur also is decreasing in intensity, and it's also disappearing. Remember that the reason why this child is crying inconsolably and they're in pain is because remember that this is shunting of blood from the right side to the left side. So you are now making sure that the blood in the systemic vascular system is less oxygenated. So there's hypoxia that is here. At the level of the tissues, remember that hypoxia is going to lead to anaerobic respiration and with resultant production of tissue lactic acid. And this can actually cause pain in the muscles. And the spells are actually going to occur in young infants. They have a peak incidence of about 2 to 4 months. And sometimes if it's severe enough, they may lead to limpiness, they may lead to seizures, myocardial infarction, cerebrovascular accidents. They may sometimes even lead to death, especially if they are untreated. So generally, as the children grow much older, they tend to learn what makes them feel better. So for example, some toddlers may actually assume a certain position. They may sometimes squat when they realize that the pain is about to come on. They're about to get into a TET spell, they squat. And the whole essence of them squatting is that you want to compress on those iliac vessels So in essence, this helps with increasing the systemic vascular resistance. It increases the aortic pressure, and therefore it's going to decrease the shunting of the blood from the right side to the left side, and ultimately it's going to raise the arterial oxygenation saturation. We refer to this as the knee to chest position. If you're doing it in infants, I'll show you what it looks like. You may get some finger clubbing you may get finger clubbing as well as toe clubbing in the older children. Generally, you're going to hear a murmur. The reason why you hear a murmur, it's because of the pulmonic stenosis. It's common misconception that people think that the murmur is because of the VSD. But remember that the VSD that is going to be associated in typical classical Tetralogy of Fallot is very large. And remember that when you have a large VSD, you don't have a pressure gradient across that VSD. So blood can flow in a very laminar way. It doesn't flow in a turbulent way. It doesn't create an abnormal sound. But if that defect was very small, it would actually create a very harsh murmur. So generally, the murmur that is going to be there as a result of Tetralogy of Fallot is more or less commonly attributed to the pulmonic stenosis as opposed to the VSD. The VSD is actually quite silent. If you actually hear a very harsh murmur because of a VSD, then that defect is probably small. If it's a soft murmur, in case of a VSD, that means that defect is very large. And so it means that if the obstruction worsens with the pulmonary outflow, it means that even the murmur is going to become quite softer. So you're going to hear this loud, harsh ejection systolic murmur, which could be about grade 3 to about grade 5 or 6, and you're going to be hearing it over the left sternal edge. It will be a left mid and even sometimes in the upper border of the sternum. You can hear it from day 1 of life, and it increases with right ventricular outflow obstruction, which is predominantly muscular and below the pulmonary valve. And the murmur will shorten and the cyanosis will increase. You may sometimes hear a second heart sound, which is as a single heart sound, because remember that the second heart sound has 2 components, an aortic component and a pulmonic component, which is known as the A2 and the P2 component, respectively. So if you have this person that has this pulmonic stenosis and the pulmonary component of the second heart sound is going to be reduced, so you're going to hear a single heart sound. You may sometimes feel a prominent right ventricular impulse, and a systolic thrill may sometimes be present. So remember that actions that are going to be increasing systemic vascular resistance, so things like exercise, things like vasodilation, volume depletion and dehydration, or anything that will increase the resistance through the right ventricular outflow, things like crying, tachycardia, all these things are going to increase the blood shunting from the right side to the left side. So these things are going to cause cyanosis. Anything that is going to be increasing the systemic vascular resistance or reducing the resistance through the right ventricular outflow obstruction, so things like volume infusions, systemic hypertension, Valsalva maneuvers, bradycardia, all these things are going to be reducing the right to left shunt through the VSD and are going to be increasing the systemic saturations, arterial saturations. And remember that the Tetralogy of Fallot is going to be a PDA dependent condition, like I said. So these are going to require the PDA to survive because they have this blood that is being shunted from the right side to the left side. So you want something that will take the blood back to the right side. So in this case, a PDA will be quite important, the patent ductus arteriosum. So what are we going to do in terms of our investigations? So we can do a chest x-ray. Remember, generally there's going to be mild to moderate cardiomegaly. There may be uplifted apex secondary to the right ventricular enlargement and a concavity in the region of the pulmonary artery segment, and this is going to give a characteristic boot-shaped heart as seen on the image on the right. You may sometimes see a right-sided aortic arch, which is seen in about 25% of the patients, and you may sometimes see this decreased vascular markings. That is because there's less blood that is flowing to the to the lungs, so there's going to be these oligemic lung fields. In terms of the ECG, it may be normal, or they may show features of right ventricular hypertrophy, especially when they're older. They may show features of right axis deviation. They may show features of right atrial enlargement, so essentially a P pulmonale. In your echocardiograph, it's going to demonstrate these cardinal features of the Tetralogy of Fallot, but cardiac catheterization may be required to actually show the detailed anatomy of the coronary arteries. You can also perform cardiac catheterization, though it's rarely needed in our case, unless if there's suspicion of coronary artery anomalies that may affect the surgical approach. For example, an anterior descending arising from the right coronary artery that cannot be clarified on echocardiograph. You can also do an MRI and a CT that can help you demonstrate the coronary artery anatomy. So here's a summary. We have a single component of the A2, as you can see here, a boot-shaped heart with oligemic lung fields. Then you have the right ventricular hypertrophy that may be there, and the features of right ventricular hypertrophy on the ECG. If you haven't watched my ECG series, I don't know what you're waiting for. I will leave it tagged as a pinned comment. You can watch the ECG series so that you understand what is going on here. Then you have the features of Tetralogy of Fallot. So remember, it's accounting for about 7 to 10% of congenital heart diseases. You get this systolic ejection murmur rather, and it's about grade 3 to about grade 5 and 6. You get this intermittent cyanosis from birth, a right ventricular hypertrophy on the ECG, and a boot-shaped heart. This is usually features that are suggestive of Tetralogy of Fallot. Now, how do we manage this? So if the neonate is actually symptomatic, we can give them prostaglandin E1 infusion. This is going to help keep the ductus arteriosum open. If they have a cyanotic spell, we can put them in the knee to chest position, calm the infant, give them some oxygen, give them some IV fluids, and sometimes some drugs are indicated in terms of the medical therapy. You can also perform some surgical repair. Remember that neonates that are going to be presenting with severe cyanosis may sometimes be palliated by giving them an infusion of the prostaglandin E1. You can begin from 0.05 to about 0.1 micrograms per kg per minute to open the ductus arteriosum, and this is going to increase the pulmonary blood flow. So in terms of the hypercyanotic spells, these ones do require some immediate intervention. So you're going to place your child in the knee to chest position. For the older children, usually they'll squat on their own when they feel like they're about to develop a hypercyanotic spell. So this is how you do it. You just simply flex the knees, you flex the hip. In this position, it helps in increasing systemic vascular resistance. It helps in reversing the shunt. You want to establish a calm environment. You want to give this child supplemental oxygen. You give IV fluids to expand their volume. If the spells increases, despite these initial measures, you can start them on morphine, phenylephrine, beta blockers like propranolol or esmolol. So generally, remember that your cyanotic spells are going to be self-limiting and they'll be followed by a period of sleep. So generally, like I said, you place them in the knee to chest position, which will mimic squatting. So this is going to be trapping your systemic venous blood in the legs, and thereby it's going to increase the systemic vascular resistance. It's going to decrease the systemic venous return, and it's going to help in calming the baby. So this position actually also increases the systemic vascular resistance, like I said, because it's going to reduce the arterial flow through the femoral arteries. You want to give them some morphine, which helps with sedation and pain relief, about 0.1 milligrams per kg subcutaneous, IM or IV. And remember that this is also going to suppress the respiratory centers and it will have a sedative effect. So it's good for this baby. In some cases, we do give sodium bicarbonate, but remember this comes with some risks, especially with use of sodium bicarbonate, things like cerebral edema, electrolyte imbalances, but generally we give 1 millimole per liter IV. So we make sure we correct the acidosis. This also helps in eliminating the respiratory stimulation in the centers. The same dose can actually be repeated about 10 to 15 minutes. We do administer oxygen. It helps with improving arterial oxygenation to a little extent. Give them a beta blocker. So a propranolol 0.015 to 0.2 milligrams per kg, a maximum dose of 0.1 to 0.2 milligrams per kg, or an alpha adrenergic agonist like phenylephrine, which will work both on the peripheral vasoconstriction. It will also help relieve the subpulmonic muscle obstruction that is going to be caused by this, that's going to be causing rather the reduction in pulmonary blood outflow. And it's also going to help in reducing the heart rate. These drugs are going to help with the contractility of the heart and the ventricular outflow obstruction, relieving it. So that's why they're quite important. Don't forget to give this child your IV fluids, give them a muscle paralyzing agent, and put them on a vent. This helps with reducing the metabolic oxygen demands. We correct any significant anemia with a transfusion. Then, of course, there should be some good dental hygiene and antibiotic prophylaxis because they are at risk of developing subacute bacterial endocarditis. So you make sure that you prevent this. Here's a table showing you the doses, the initial dose and the maximum doses, and the route of administration of esmolol, morphine, phenylephrine, and propranolol. So if your standard measures don't control the spell, then generally your systemic blood pressure can be increased with ketamine, about 0.5 to 2 milligrams per kg IV or 2 to 3 milligrams per kg IM. You remember ketamine is also beneficial because it has a sedative effect. So it's going to be used to increase your systemic vascular resistance. It helps also to sedate the baby. And then, of course, this has been known to terminate your hypercyanotic spells, but make sure that you do consult before you give this drug. So generally, initial management is going to be medical, then with your definitive management being surgery, which is often done at around 6 months. So it's going to be involving the closure of the VSD, it's going to be involving relieving the right ventricular outflow obstruction, sometimes with placement of this artificial patch, which is going to be extending across the pulmonary valve. So in terms of infants who are very cyanosis in the neonatal period, you can sometimes perform a palliative procedure that can sometimes even help shunting blood to increase the pulmonary blood flow. So often this procedure is known as a modified Blalock-Talsic procedure. So it's often going to be done where you place this artificial tube that's going to be between the subclavian artery as well as the pulmonary artery. So you sort of create an artificial shunt. Sometimes ballooning or balloon dilatation of the right ventricular outflow can be done. Those are the important things that you need to know in terms of Tetralogy of Fallot. If you enjoyed this video, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.